Good morning. I'm excited to talk about this concept of skin sensitization and food allergy. We just heard from Gideon Lack, who really sort of pioneered lots of this concepts in human of the skin being site of sensitization and the role of foods being reduced that way. So I'm going to take a step back and look at, can we make the skin better? Can somehow we improve eczema? Could that make a difference? And I'm always going to start with a patient story. So this is a classical patient with atopic dermatitis who has full-term infant growing fine, but has asthma, and mom has asthma, dad has allergic rhinitis. He's on a pretty normal diet, but really has eczema everywhere. So we recommend good basic skin care, soak and seal, moisturizing with a good moisturizer such as CeraVe or Vanicream or Eucerin, already the equivalent genetics. Treating with triamcinolone for a week, get things better, then switch to 2.5% hydrocortisone for sort of the acute symptoms, some basic skincare. They now come back a month later. Eczema is now much better, but they still need daily topical steroids. Now, on exam, they still have eczema throughout the abdomen, back, and legs. Since they have persistent eczema, we skin test. So you skin test to various foods that they're eating, figure maybe that's an allergen. They were positive to 4 foods: milk, egg, wheat, and soy, negative to lots of other small things they're eating. So you do a food challenge to figure out, hey, they're really allergic to milk and egg, and negative to wheat and soy. So the question always is, did the milk and food allergy come first, or did the eczema come first? So when you begin to look at how common this was, and this is a study from U. Sampson 35 years ago now, that looked at these patients with atopic dermatitis, and this really started this question. And they looked at this, in that population, over 40% had some food allergy. Many of them outgrew it quickly, but there was a lot of food allergy in these patients with severe atopic dermatitis. If you sort of just assume it's just skin testing, that can be really dangerous. So this is work that David Fleischer published 9 years ago. And just looking at testing, that doesn't really work because most of the time you test, they're negative. So it was like 90% of the time when these kids coming in with atopic dermatitis, either avoiding it to due to testing, avoiding it to due to reactions, or avoiding it just because of other siblings, most of the time they're negative. So you can't just rely on that. We need to have a better way of testing. So we know there's a lot of false positives out there. And if you begin to look at it, the rate of sensitization, this is just having IgE, is really common, anywhere from 30 to 80%, depending on severity of AD. So there's a lot of skin causing positive IgE, but the rate based on food challenges is much lower, anywhere. So someone with mild food allergy is about 2 to 4%. As you go up in severity, it comes 8 to 10, sort of in the moderate, and about 30% in the severe. So the question is, what's coming first? And I don't think we really know. Going back to something what I did with Raif Jaha's lab many years ago, we took a mouse and you put ovalbumin, good old egg protein, on a mouse, and the mouse become allergic to egg. And then the same mice, you can make them have asthma or do EOE and lots of other things too. But this was a way to make a mouse allergic. You would just put the egg albumin on the skin. And we actually knew at that time that you putting the egg on the skin was the best way to make the skin, and you had to do it by tape stripping. Tape stripping came to play a key role, so you needed to do it to inflame skin. Intact skin wouldn't work, but they actually desensitize it. But through inflamed skin led to an important idea. And this led to all the stuff that Gideon Lack is now famous for. He took this many, many steps forward and showed that treating kids with atopic dermatitis early on with a food, giving them food, you can really prevent them from developing food allergies. Make that sensitization just sensitization, not true allergy. So I was involved in several studies trying to look at what about could we make the skin better. So one of the studies I was involved with is called the SAM study, the study of the atopic march. And this was a 6-year long study that we treated patients with atopic dermatitis early on. We had emollients initially, and if they didn't get better, we treated them with pimecrolimus or vehicle. And if that failed, they would got on to low dose fluticasone because that was approved for that strength. And we treated about 1,000 patients. The idea was to actually prevent food allergies and prevent the atopic march. Could we make things better? So looking at these kids, not surprisingly, looking at how much food allergy are, the patients who had more severe eczema had more food allergy. So the mild patients had about 8% of the patients had some food allergy. well, going up to about 25% in their severe patients, very similar to what has been known in the literature. So there's a lot of food allergy went up with over time. But the question was, did this aggressive therapy, did it make a difference? So the blue bars were the ones treated with primacolomus first, and the red bars were treated with a control, a vehicle, just moisturizer first. It made no difference. If anything, the trend was getting the opposite. Patients tend to be who were treated with control actually maybe did a little bit better. And if you normalized out for severity of people's eczema, it made absolutely no difference. There was a trend going the wrong way that patients didn't get better. So treating aggressive AD didn't seem to help. So suggesting that maybe that was not the way to go, treating it on the skin, that didn't work. What about preventing AD? So maybe we can prevent it. So the idea was to put on moisturizers early on. So there have been two large-scale trials that were published last year, and the idea was to treat moisturizers and really to reduce atopic dermatitis. And they're looking at food allergy. One study has the results, and the other results are still pending. Can we prevent food allergies from just treating, making the skin better? So one was a study out of the UK, which are basically 1,400 infants, and they were randomized to hormonal control and with regular skincare. And there was a similar study out of Norway and Sweden, where we're now 2,400 infants, and they were randomized to no advice, early use of moisturizers, early use of foods, and early use of emollients or foods. What would they see? So in the BEEP trial, this is the early eczema study, they looked at, did we see any difference? And when you look at that, you see that there's really no difference. There was no improvement in the skin by use of moisturizers, whether you looked at clear, almost clear, mild, moderate disease. They also looked at food, developing food allergies to milk, egg, or peanut, and them individually. There was no improvement at all in the way it would work out, including for sensitization. Interestingly, there was a trend to less sensitization in the control group with no extra moisturizer compared to the moisturizer, suggesting either that things were not getting better, or maybe they were using the wrong moisturizer as possible. So there's another study called Prevent Aldal, another eczema study that we took, was the one from Norway and Sweden. And again, they looked at those four groups: nothing, skin moisturizers, early food, and combination. So if you look at the treatment of atopic dermatitis, which was the primary endpoint, there, if anything, the control group by doing both made a difference, but just moisturizers by themselves didn't seem to help at all. If anything, they're beginning to trend the wrong way. If you look at per protocol populations, again, there was 8% in the non-intervention, 10% in the control group. The food intervention group was 11%. It seems you need to do both. Both, as at 5%, that trending the right way wasn't statistically significant, but it really suggested that maybe that was the way to go. So maybe you need to do both. If you look at here, the risk plots, you can see on the right, this suggesting that the intervention made things worse. On the right, the intervention made things better. None of them were significantly improvement for atopic dermatitis, whether or possible AD. These interventions did not make a difference. Giving foods early or doing moisturizers don't help. The answer is maybe we need to do a little bit of both or potentially treat it a different way. So, what may be the different way? How else could we do this? And one is we know that skin can definitely lead to sensitization. Clearly, in mouse models, all the work by Gideon and Lack has shown that skin can cause sensitization. But it looks like treating the AD to prevent or treating the AD early does not seem to have effect on food allergy development. That doesn't seem to play a role. Maybe if we need to do a combination of treating the skin early plus adding foods may be the right way to go, or maybe a systemic therapy. We know when we think about developing AD, there's a complex pattern. It's more than skin deep, as people like to say. There's an involvement of barrier defect. You get an induction of your alarmins with IL-25, IL-33, and TSLP activating your Langerhans cells in your basophils, leading to activation of your Th2 and dendritic cells. So maybe treating systemically early to block that activation pathway with either IgE, anti-IL-4 receptors, or anti-TSLP or anti-IL-33. Blocking early on in that pathway will make a difference. I think we need to begin to think about food allergy not just as a local disease, but a systemic disease, and begin to treat things on a broadest aspect. And thank you. I'm happy to answer questions during the question and answer period.